some of the new drugs are much better, some are only marginally better. Is he in a good position to at least look at that financially and say, look at the difference in outcomes, look at the difference in price, maybe price is important? What do you think?
Well, I am concerned that the drugs, that the newer drugs don't price themselves out of the market. I mean, and I think I don't work for the pharmaceutical company. And I would hope that as new drugs come out that offer benefits to our patients, that those decisions will be made wisely.
Should we talk about Hep C?
Well, yeah, tell me about Hep C. I mean, since you brought it up, I mean, clearly what you're talking about is the fact that Hep C drug is very expensive, and yet it's curative.
Yes.
Right. So that's a cost-benefit discussion the insurance companies have had with physicians. What did you mean by bringing this up?
So, you know, when the Hep C drugs first came out, they were extremely expensive, and we ended up managing it. We chose preferred products. We put in prior auth criteria. Doctors were kicking and screaming. They did not like that because they said, my patient has Hep C, I need to treat them. But because of the inexorbitant prices, it was just unbearable. So we started to manage it, and slowly, competition started, and the prices went down. So I think, you know, as we think about HIV, I think we've seen it work with Hep C. I think we can make it work with HIV, but we need collaboration.
That's a good example, though, that I'll say that I've had very frustrating experiences with payer sources in the Hep C arena, in that one Hep C product in particular was 7 pills broken up in a BID fashion, so lots of pills, and an alternative was 1 pill a day. And we were told in many situations that we needed to give the 7 pill a day, twice a day dosing with much more drug-drug interaction and tolerability issues because of price.
What was the difference in price?
I don't know.
Well, again, I don't think we are talking about going back to the 6, 7 BID, TID type thing. I'm looking at the 4 preferred regimen, quote-unquote preferred regimens. Again, you've got a couple STRs, you've got a couple other non-STRs, a couple manufacturers here, but you've got 2 drugs versus 1 and 2 different manufacturers. I think it's different to maybe have a conversation about kind of leverage one of these manufacturers versus another to set up a first-line strategy, and that's all I want to do. Again, I don't think we're talking about going back to the 7, 8 type of regimens.
So what I would encourage you to do is get HIV expert treaters or clinicians or pharmacists to sort of incorporate more than just price, to sort of say, yes, but can we pick something that, let's say, has the high genetic barrier to resistance, has the least drug-drug interactions? Is there one of these that we might zero in on and say, this is, if all things were on the level playing field, if it was the same cost, which one out of the 4 might rise to the top, as darunavir has sort of risen to the top in the protease inhibitor class?
Let me see if I heard you right. You want to talk to him about this, and he wants a conversation with you. What am I missing? Isn't this both? Aren't you both saying the same thing? He thinks so.
I think we are.
Then why did you react with such alarm? No, he can't control my practice.
Suspicion. Suspicion.
Well. And
he's not a Sith Lord.
No, but rightfully so. I get it. But I think there are some misaligned incentives in the system.
Okay.
But I also think that there's a misperception about everything we do is about cost, and that's not true. Again, we don't have to spend time in that soapbox. But I think there's a misperception of what we do. We do want to do the right thing. We still are looking at efficacy and safety. It's not just cost. But at the same time, I want to have a conversation about valuing the nuanced difference in efficacy. Is it really worth twice as much money? Having those types of conversations. Because before, a physician's going to look at that and say, I don't care, this is $50,000 and this one's $20. This one's that much better. I'm going to go with the one that's that much better.
My responsibility is to my patient.
Right.
Right? And you also have a responsibility to the patient. You also have a responsibility to society. And you're sitting in the middle smiling because you don't want to get involved in this argument. So where do you fall on all of this, since I'm going to moderate it?
You know, I I totally understand the managed care perspective because it is a societal issue. And one thing about HIV that does make it different from other disease states or conditions is that diabetes is in isolation. It's owned by the individual. Even cancer is within the individual, but HIV is something that's a societal issue because, like I mentioned before, if we get individuals to be undetectable levels, we can prevent transmission. So all of us own it. And so as we think about from the payer perspective, all of us are paying for it. So that collaboration really is important.